Hey guys, Dr. Rosa. This is the November 2022 joint training between North Metro and Thornton Fire. And today we're going to go over some CQI lessons learned. Dr. Foster and I put these together based on the last year's worth of case reviews and CQI and some high value things we could talk about that will make a little bit of a difference in how well we do our jobs, as well as how smoothly we can do stuff and maybe make some stuff more simple and straightforward for you. So we're going to have three sections to this. The first one is going to be Dr. Foster talking about pronouncements and how that works conceptually. And then I'm going to do a brief discussion after that on refusals. And then after that, we're going to talk about patients who look healthy but actually have some occult illness or injury going on based on things that we've actually seen in practice and in case reviews. So anyway, we'll start off with Dr. Foster's video, and after that, we'll come back and we'll go through mine.
So one of the areas as we looked at our CQI process and getting involved with you guys in the field, as well as fielding some questions about odd things that have come up, is the broad category of dead patients. So hopefully going to break that down a little bit for you guys, make this a little bit of an easier thought process to follow, and also talk about what documentation requirements we have specifically for patients who are deceased. So to start, there's sort of two broad categories of patients who start out pulsosynaptic and end up pulsosynaptic. Of course, there's a whole other category of patients that are transported and have a transition of care, or who end up having return of spontaneous circulation. But for patients who start out dead and stay dead, they really fall into one of two categories. And those are either a standing order pronouncement or a termination of resuscitation. So we're going to start out by talking about standing order pronouncements. And these are standing order because there's really very little ambiguity, right? So whenever you have a dead patient and you're declaring a time of death, you have to do this under the direct supervision of a physician, right? But because these patients have really no ambiguity, you can do this under the direction and licensure of your medical director. And so therefore, these don't require a call to another physician or involvement of base contact. And the kind of basic documentation that you need to have for a standing order pronouncement is why the patient meets the criteria for a standing order pronouncement, what their time of death was, and what your medical director's name is. There are really three categories of patients that fall under standing order pronouncements: those with obvious signs of death, those with a do not resuscitate directive, and then certain categories of patients who arrest secondary to traumatic injury. So we'll kind of go through each one of these and talk about the nuances. So obvious signs of death, of course, include things like rigor, being cold, mottled, having dependent lividity, and we'll extend that to any time we're called and we find human remains. So barely recognizable fire victim, drowning victim, those sorts of things. The documentation that we have to include for patients who meet standing order pronouncement under obvious signs of death are: when was the last time someone saw them alive? When did we find them? We need to document that they have a lack of pulses and that they're apneic, and what specific signs of death are present. So for example, called out for unconscious, unresponsive, 72-year-old female. Patient was found with evidence of dependent lividity, with rigor, and cold to the touch. Meets criteria for standing order pronouncement. And then, of course, time of death and the medical director's name. Things that we don't need to include in our documentation: we really don't need to document asystole, so you don't have to put up a cardiac monitor and look for a cardiac rhythm. And we don't really need a super detailed physical examination. And what I mean by that is, as we've reviewed some of these charts, I think what we've found is that perhaps there's some remnants of a template that's getting carried over into patients who meet criteria for standing order pronouncement, things like abdominal exams and extremity exams and that sort of things. So, if you're not doing a super detailed physical examination, which is generally not required in these cases for obvious death, just make sure that you're checking your template and that your documentation is really representing what it is that we did for this patient on scene. So moving on from patients with obvious signs of death to patients that meet criteria for a standing order pronouncement because they have a do not resuscitate initiative or directive. And what constitutes a DNR, right? So there is some good detailed information in the Denver Metro Advanced Medical Directive protocol. So I'd encourage you to go back and review that. But obviously the kind of most official form that we're looking for is the MOST form, the Colorado MOST form. This is a state-specific form that allows the patient to legally communicate their wishes about what should happen to them if they are incapable of making their own decisions, right? So most of us go kind of right here to this box A or the top box on this form, and we look to say, okay, did they check yes or no whether or not they want CPR? And that's kind of the most important place to look for patients that we're talking about today. So patients that are in cardiopulmonary arrest. That box B is more important, to steal a line from The Princess Bride, which is still one of the best movies ever. If they're only mostly dead, then you really kind of want to look further down into that category B to figure out what the right treatment directive is for this patient. But for patients who are in cardiopulmonary arrest, we want to look at box A. Did they check yes or no? Do they want CPR? So what happens if we don't have a DNR form that's available, or they can't find it or whatnot? Can you utilize things like a bracelet or a family member to communicate the patient's wishes? Yes, you can. It's very important that you know that you're supported both by the Denver Metro protocols as well as state law in following the directives that are communicated to you at the scene, and that does not necessarily have to take the form of a Colorado MOST form. And the important thing to realize here is that when you look at decision making in general for patients, there's a hierarchy there. And that always follows the order of the patient first. So the patient gets to make their own decisions unless they do not have decision-making capacity. And that's really important to realize. And that MOST form really does represent the patient's decision-making. So whenever possible, we should honor that MOST form because that is a legal document that communicates the patient's wishes to you should they be unable to communicate them themselves. Power of attorney comes next in the decision-making hierarchy, and a power of attorney is a legally designated individual that the patient has selected to be able to make decisions for them should they be unable to do so. And that person does supersede other family members. So important to realize that if there's multiple people in the room, if someone has been selected as a power of attorney, they are the ones that have the final say-so. And then if that's not designated or that person isn't there or is not able to be communicated with, then other family members can, become the de facto decision maker. But it is important to realize that the patient's wishes do supersede all of those things, and that those other things don't take effect until the patient does not have decision-making capacity. So I did education with one of my friends who's a palliative care doctor and emergency physician. And, she said, oh, the aunt who's the power of attorney would love to make decisions, for the patient, but they just don't realize that they don't get to do that as long as the patient is still decisional. So again, kind of mentioned this, but the MOST form represents the patient's wishes, and this was done in a legal format when the patient has decision-making capacity. So if there's conflict there between the family members that are present on scene and the MOST form, we really should be doing what we can to honor the patient's wishes, because that is the appropriate decision-making hierarchy. And those wishes should be honored. So what do you do if you're on scene and you have a MOST form that's legit and filled out, but the family says, no, they want to be resuscitated? And one of my favorite terms that came out of that meeting with my friend, the palliative care physician, was the seagull family member. So somebody who's never around but kind of flies in at the last minute and then it's on everything. Right. So, but in all seriousness, what should you do if you end up in a situation where what the patient has communicated that they want and what the family members say that the patient wants are at odds, and the patient is no longer able to communicate for themselves. Really, I would encourage you guys to try to look for alignment. In these situations where these decisions are really contentious and at odds, you're never going to get anywhere by just putting your foot down and taking a firm stance with the family member that they need to adopt your point of view. That's never going to align the viewpoints. That's never going to get the kind of collaborative decision making that you're going to need here to move the needle. So some of the things that I've used in the emergency department, as well as some of the recommendations from, again, my friend, the palliative care physician, is to really look for alignment and remind the family members or the power of attorney of their job. And their job is not to carry out their own wishes. Their job is to carry out the wishes that the patient has already communicated to them, because they're no longer able to do so. So it's not the power of attorney's wishes, it's the patient's wishes that we need to be carrying out here, and try to recruit those family members as advocates. And one communication technique that I've found helpful is you can say to that person, could you just imagine if your dad was standing here, what would he tell us to do? And I feel like sometimes that helps to really bring the task at hand into focus, right? Which is, we need to be carrying out their wishes. And sometimes the family members will say, oh my gosh, he would never want this. He would kill me if he saw this, right? So if you can get everybody on the same page and in agreement to discontinue resuscitation, great. If you can't, or there's some doubt there, or something doesn't feel right to you, I would err on the side of continuing resuscitation and transport, and let us go ahead and sort that out on the back end. So here's another situation. What if you initiated resuscitation and then a family member arrived on scene, or someone produced a DNR? What do you do in that circumstances? Can you stop resuscitation? Do you have to call for a termination? How do you document that? And the answer is that this patient still meets criteria for a standing order pronouncement. So that patient has expressed their desire to not undergo resuscitation. They meet criteria for a standing order pronouncement. Just because we didn't know that at the start doesn't change the fact that they still meet criteria for a standing order pronouncement. So yes, you may discontinue resuscitation. No, you do not have to call for a base contact. You can go ahead and pronounce that patient under the standing order pronouncement guidelines that we've talked about under the name of your medical director. Okay, moving on to the last category of standing order pronouncements, which is trauma arrests. And trauma arrests also come in three flavors. So those include patients with a blunt traumatic injury, patients with a traumatic injury, and then there's kind of a caveat for what they just call a non-survivable injury, regardless of the mechanism. So the first one, blunt trauma, those include blunt traumatic injury in patients without signs of life. And that signs of life are defined as things including purposeful movement, pulses, breathing, or reactive pupils. And if you have a patient with a blunt traumatic arrest that does not have signs of life, they meet criteria for a standing order pronouncement. And the reason that they meet criteria for a standing order pronouncement is because these patients have no ambiguity. They are dead, they are not resuscitatable, and these patients' survival is dismal. So these patients meet criteria for a standing order pronouncement. You don't have to call for base contact, and you don't have to get another physician involved. Blunt trauma arrest without signs of life, standing order pronouncement. Penetrating trauma, we extend that a little bit and say that if we suspect that the time of arrest has been greater than 10 minutes, or if it is 10 minutes without signs of life, they also meet criteria for standing order pronouncement. And again, penetrating trauma has a little better of a chance at an intervention that can improve their survival, which is why these criteria are a little bit different than blunt traumatic arrests. But still, the survival rates are really quite dismal. And if you are over that 10-minute mark, they're really non-existent. So again, no ambiguity here. These patients are not survivable. They meet criteria for a standing order pronouncement. And then finally, that non-survivable injury, just kind of calling out specific things that regardless of whether it was penetrating or whether it was a blunt traumatic mechanism, these are patients that don't have any ambiguity. They're dead. This is not survivable. And that includes things like decapitation, massive burns without signs of life. I can't remember exactly how they phrased it in the Denver Metro protocols, but it's something along the lines of massive blunt trauma mechanism, but basically meaning the patient is squished or decomposing. There are a couple of exceptions to the trauma arrest standing order pronouncements, and those all exist for really specific reasons. The first one, pregnancy greater than 20 weeks, and you guys hopefully remember from our OB training, the reason for that is that you have two potentially viable patients. So even if you have a mother who would meet criteria for a standing order pronouncement, if you have reason to believe that they are greater than or equal to 20 weeks pregnant, we should initiate resuscitation and transport with the off chance that there may be a survivable fetus there. The second one is lightning strikes or electrocution, and that is because those cause such a hard reset in your brain that those patients can have lack of signs of life, even though they are potentially viable, things like blown pupils, things like arrhythmias, those sorts of things, but do still have a potential survivable injury. So lightning strikes or electrocution. And then things that basically improve your chance for neurologically intact survival, even with traumatic injury. So things that lower your body temperature, hypothermia, drowning with submersion for less than 60 minutes, or avalanche victims, all kind of the same physiology there. Okay, so that's it for standing order pronouncements. And we'll move on from here to termination of resuscitation. So termination of resuscitation is a different category, and these patients don't meet criteria for standing order pronouncement because they're not clearly permanently dead, right? So we've initiated some resuscitation, and we need a base contact for physician consultation in order to obtain that physician pronouncement that we need to declare a patient dead and obtain a time of death. These include patients where we don't have any return of spontaneous circulation despite 30 minutes of good resuscitative efforts. Know that there's a caveat that you could always call for pronouncement earlier if the patient is clearly futile for some reason, or if after that 30 minutes of resuscitation we haven't regained any sort of shockable rhythm. Those are the two most common scenarios where you'll find yourself where you've initiated resuscitation and then you're calling for a termination and pronouncement to base. The documentation requirements for this include the time of death, the name of the physician from the base contact, and then, of course, just another reminder from reviewing a lot of these charts throughout the year to make sure that you've removed any sort of references in your template to a standing order pronouncement if you've called for a termination, because those are two completely different processes, and it needs to be pretty clear exactly which mechanism we used to pronounce this patient dead. So hopefully this helps clarify a little bit of kind of the thought process and categorization and documentation needs for patients that we find pulseless and apneic, that stay pulseless and apneic. But we've had a couple of circumstances come up throughout the year that sort of throw a wrench in this. And I think it's worth kind of talking through the thought process behind this, the logic behind this. God forbid we ever find ourselves in the same situation again. That will hopefully help to guide our decision making, or at least give you guys a framework by which to work under. One of the first examples that came up where the protocols and our medical direction really haven't provided you guys really good, clear guidance is the instance of a stillborn infant, right? So delivery in the field where the baby is born pulseless and apneic. So in thinking about this process, here's some guidance to hopefully, God forbid you ever find yourself in this situation, can provide you a little bit more support in your decision making. So when we think about infants that are born pulseless and apneic, or a stillborn infant, they really will fall under three categories. So we have a non-patient, we have a patient that'll meet criteria for a standing order pronouncement. And then we have a patient where we've initiated resuscitation and have terminated resuscitation prior to transferring care. I'm going to expand a little bit on each of these three categories, starting with the non-patient category. And this is going to include any situation where there is a pregnancy that is pre-viable. And although we know that the edge of viability is north of 20 weeks, we're going to use 20 weeks in order to keep things consistent with the rest of our protocol set. And any pregnancy loss that is less than 20 weeks gestation is considered a miscarriage. But you'll see here on this chart that I have this separated out into miscarriage and then a pre-viable loss, because I do feel that when you're in that situation where someone has had passage of fetal tissue or their products of conception, it is a substantially different experience if that is an early pregnancy loss and not recognizable versus a more, late pre-viable pregnancy loss, which could be quite recognizable as a fetus. So what could you use? Let's say you're in a situation where you have somebody who's had a pregnancy loss and they're not certain what gestational age they are, or you think you may be kind of close to that 20-week mark. A good anatomic landmark that you can use is whether the eyelids are fused. And if the eyelids are fused, then this is a pre-viable pregnancy, a pregnancy under 20 weeks. And if you do find yourself in this situation where you have a non-patient pregnancy loss because the patient is pre-viable, then what sort of documentation do you need to do? The fetus does not require their own medical record because by definition they are not a patient, but this is something where we would include documentation about what we saw with regards to the fetus on the mother's PCR. And we'll move on from the non-patient category to the standing order pronouncement category. So in what situations, if you have a stillborn infant, would the patient meet criteria for a standing order pronouncement in the field? And I wrote that down as obvious signs of death. But this should really occur very few and far between, hopefully never in your career. And the one physical exam finding that I would be comfortable to say we should include under a standing order pronouncement is a baby that is truly decomposing and or just falling apart. And this would, by definition, be a pregnancy that is either at or greater than 20 weeks and has those physical exam findings that would meet signs of obvious death for standing order pronouncement or decomposition. Right. So in that circumstance where you have a gestational age that is at 20 weeks or greater and the fetal tissue is really just falling apart, you do need to document that as its own patient because this was a viable patient with regards to gestational age. So they do require their own PCR and that documentation that's required for the standing order pronouncement would be the same as any other documentation we would do for any other standing order pronouncement. In the absence of that, any patient that is not obviously pre-viable or meeting criteria for obvious signs of death, which again, we've said really should only be under the circumstance of a decomposing or falling apart baby, we should default to initiating resuscitation. So we acknowledge that patients can have abnormal skin colors, muscle tone, may have abnormal facial structures or abnormal skeletal structures, missing limbs, those kinds of things. But in any of those circumstances, the default from our standpoint should be to go ahead and initiate resuscitation, even if we have concerns that this may not be a viable patient. If we have initiated resuscitation and made the decision that we're going to carry out this resuscitation in place in the field, then the Denver Metro protocols advise that if there's no response after 30 minutes of appropriate resuscitation, you could consider a discussion of goals of care at that time and consider transitioning to a termination. If this is the situation where you find yourself, then this patient will require their own PCR. And patients where we've initiated resuscitation and are now looking to terminate resuscitation do need to have a call-in for a pronouncement with, again, the same documentation requirements for termination of resuscitation that we would have for any other termination of resuscitation. And that includes the time of death, the physician's name from the base contact, and again, when we're doing the documentation, just make sure that we don't make any reference to a standing order pronouncement if we are operating under the situation of a termination. And then the next question that came up in this circumstance is, well, what do we do with the stillborn infant, right? Is this something where we transport with the mom? Do we leave this in place for the coroner? And we had some discussion with the receiving hospitals to see, what the best practice would be. And our recommendation to you is to keep the baby with the mother if possible. And if you're in a situation where you have two ambulances that are transport both to the same hospital. All right, you guys, as I was reviewing the material that I recorded yesterday, I just realized that is a lot of information in a fairly complex situation. So wanted to run through this just one more way, formatted a little differently to hopefully clear up any remaining confusion that you may have regarding the discussion on stillborn infants. So let's say we are called out to a field delivery and the baby is born pulseless and apneic. And the first question you're going to ask yourself is this a gestation that's either greater than or equal to 20 weeks? And if the answer to that is no, because you notice that the eyelids are fused and the mom does not have good dates, or the mom has good dates and is clearly under 20 weeks, then the fetus is not a patient, does not require resuscitation, and does not require a PCR. Again, that documentation will live in the mom's chart. So kind of rolling back here, if you have a gestation that is greater than or equal to 20 weeks, is the baby decomposing or falling apart? If the answer is no, which is going to end up to be most deliveries, hopefully, we're going to err on the side of initiating resuscitation. And in that circumstance, the baby needs a PCR. And if we do end up resuscitating to the point where we're going to terminate in the field, needs a base contact for a termination of resuscitation. If the baby is decomposing, then we can go ahead and call that under a standing order pronouncement without any resuscitation effort. The patient will require a PCR, but does not require a base contact because you'll do that pronouncement under your medical director's standing order pronouncement. So just one more format, again, hopefully to make this clear. So if you have a stillborn infant, they can fall into one of three categories, either a non-patient, which is a gestational age less than 20 weeks. They could fall under a standing order pronouncement if they are greater than or equal to 20 weeks and the baby is decomposing. And in all other circumstances, we should err on the side of initiating resuscitation. Hope that helps clarify, and we will move on to our next strange scenario. Kind of the second strange circumstance that came up this year, actually more than once, is what do we do if we're on the scene of a homicide? So if we get activated and it's an active homicide scene, can law enforcement keep us from accessing a patient? If we were called out to assess someone, is the victim of the homicide a patient at all? What sort of documentation do we need to provide? And then if we are not involved in the patient care, how do they end up getting pronounced as dead? So the first thing to know is that law enforcement does have the authority to bar fire or EMS, or anyone else for that matter, entry to a crime scene. So that is within their scope. If they say you may not come on the scene, we should not go on that scene. And that supersedes our duty to provide patient care. The second question, is this a patient at all? It is only a patient to you if you've made contact with the patient. And that's because that establishes that patient-provider relationship. So if you have not made contact with a patient, then it does not require documentation as such. If you do make patient contact, then the documentation is required as a PCR. If there's no contact, then we'll complete a fire report, which will include, description of the situation, our attempts to make contact with the patient, and details regarding the law enforcement direction to remain outside of the scene. In that circumstance, the patient ends up to be pronounced under a process with law enforcement under the direction of the coroner. So that's how that ends up happening. I think if anything, the last couple of examples and just some other situations that have arose this year just go to show that really things are oftentimes not black and white. And if you do find yourself in a situation with a patient in cardiopulmonary arrest and the right answer is not immediately clear, I would say err on the side of initiating resuscitation and try to reach out to your resources. And those can include your officers, North Metro, our SAM officer, and that can include medical direction as well. So when in doubt, err on the side of resuscitation, reach out to your resources for help. All right. So I hope this helps provide at least some clarity around the process for patients in cardiopulmonary arrest, and helps you to understand kind of the thought process as we talk through some of those more complex situations. Please feel free to reach out if you have anything interesting or confusing, and I hope the rest of your training is great. Thanks, guys.
All right, guys, so that was a good discussion of how to think about pronouncements, termination, resuscitation, and how to work that through. So I hope that simplifies how you think about the process and makes it a little bit smoother and easy to document on. So now we're going to work on refusals, and again, looking at some things that have come up in CQI and in questions and comments and some real cases that we've dealt with. So basically, let's just go over refusals in general to get back on the same page, and then talk about some of the issues that we want to be very cautious of. So basically, for refusal, not everybody wants to go to the ED that we encounter, even if they have some severe things going on. And not all of them want to go to the ED with us, or they may want to stay home. And so they don't want to ride, they don't necessarily need a ride, and we have a process for refusing transport. So part of the foundations of this process in the Denver Metro protocols and in EMS in general is that our refusals are going to always be against medical advice, which means that when someone calls 911 or someone call either for themselves or they call 911 for somebody else, our assumption is that they're worried there might be an emergency that the patient needs help with, the person needs help with, because they may not be a patient, which we've talked about in some of our consent and patient-no patient stuff. There are some systems in the United States that use something called a paramedic-initiated refusal, where basically the paramedic says to the patient, hey, look into what's going on here. I don't think you need to go to the emergency room, or even to the point of, I'm not going to take you to the emergency room even though you want to go, because I don't think you have to be there. Many of those systems have huge liability and professionalism problems related to that practice. So Denver Metro, we do not do that. All of our refusals are technically against medical advice. Now, there are certain opportunities for things like ET3 and telemedicine, alternate destination stuff. I don't want to talk about those issues because those add in an extra layer of protection, extra layer of care by bringing in some specialized protocols, specialized training, or specialized personnel who are very good at thinking about follow-up and alternative plans. And so I don't want to open up that can of worms. I want to talk specifically about just you as a medic or you as an EMT. talking to somebody who you've encountered on the street from a call and working through the refusal process. So stepwise, basically we start off through our protocols and we go to the patient, no patient. We've talked about this before in our consent update or earlier in the year. And just remember that even though the patient may be technically a no patient, you might still want to document on that, either in the fire notes or to generate a PCR on that so we can look at it. And the philosophy there is that the faintest ink is stronger than the strongest memory, because our memories are incomplete. But something that you wrote down in real time to document what's going on, if it's a weird situation, a high-risk situation, or something like that, capturing your thoughts in real time is very protective because it shows what you were thinking then, and it also is information that nobody can argue that you kind of changed your mind after or trying to cover things up or things like that. So it can be very valuable. I don't think it's very common that we would have to do documentation for no patient, but sometimes you may feel that you knew, and if you do, please go ahead and do that. The next is, does the patient have decision-making capacity? Because this is an against medical advice refusal, the patient has to know what the advice is, appreciate it, and then choose to go against the medical advice. So do they have the ability to choose, communicate, understand, reason, all the stuff right out of the Denver Metro protocol algorithm? And then one thing to think about here is we've had some refusals of where a 17-year-old motor vehicle accident basically refused for themselves. Minors generally can't consent except in some very narrow stuff related to sexually transmitted diseases and substance abuse, which are going to not really apply to the EMS realm most of the time. So if you have a minor, we got to come up with a different plan. The minor can't consent for themselves. They can't enter into contracts unless they're emancipated, which again is kind of a rare thing in Colorado. So step 3, you have to actually lay out the risks and benefits of going to the hospital versus staying home for the patients. They need to know that information for informed decision making. So you got to lay out what is it you're worried about. What do you think the patient could have? What things do you just not know that you can't really figure out or lay any details on right there for the patient. Say, hey, I don't know what could be going on inside your abdomen with this pain. It could be a lot of different things. Without going to the ED, I don't think we could definitively tell you that whatever it is not dangerous. And so we want to lay those out and then document what you've laid out, not, verbatim, but you want to capture some of the highlights of what are specific issues that you're worried about in this patient that you told the patient you were worried about, and not necessarily a comprehensive list, but it's nice to have some detail in that rather than just having a templated, all risks were communicated to the patients or something. So then there's another differentiation in the Denver Metro protocol. So we have to look at, is this patient high or a low risk refusal? So low risk refusals are standing order. The patients will have your reassuring vitals, no apparent life-threatening injuries or illnesses, maybe a reasonable plan of what the patient's going to do instead. So these are the kind of patients, and the way I think about this is that if this patient's going to refuse, I'm probably not going to give another thought to how that patient turned out. I'm comfortable with them going home. I'm comfortable with them not going to the ED. I'm not going to recommend that they do that because, again, it's against medical advice, but I'm also not going to lose a second sleep over it. High-risk patients are patients who either within the complaint for the particular or the protocol for the particular complaint or issue that they have, there are some high-risk features or they would need some aggressive intervention, or you're just worried for some reason that this isn't going to turn out well for the patient. The patient's making a bad decision or at least making a risky decision. They're likely to deteriorate, or maybe the patient's plan is just unreasonable. With high-risk patients, we want to have base contact. And so what this does, again, is it helps mitigate some of the liability. You also have the option of having the patient talk to the base contact physician on the recorded line to capture the patient's rationale about why they want to do this. That's also helpful. Again, that kind of real-time recording of us recommending this high-risk patient go to the emergency room and them refusing with whatever reasons they have on a recorded line with the physician. That's a very hard thing for the patient or the patient's family to come back after the fact and say that we didn't do all we could to try to get them to go when we were worried about them being high risk. And there's a saying that I always learned is the reason that there are 6 handles on a coffin is you're not supposed to carry it by yourself. So enlist patients' family members, enlist the doc on the biophone. Maybe have one of the other medics or somebody else on the crew's got a better rapport with the patient potentially to try to convince the patient when they're high risk or to help them come to a good decision there. So keep those things in mind. And then after we've gone through that process, our step 5 is document. So details are helpful. Specifically, what did you tell the patient your worry was? What did you actually see in the patient that did worry you? Why was this high risk, or not even high risk? Why was this something that our recommendations go to the hospital? If you're not worried about the patient, lay out the things that are benign and that make this patient low risk. Reassuring vital signs, a benign exam, the patient having a really good plan. If you talk to family members, friends, or something, who were they? That way we can basically look back and say, hey, now you're telling us that if you'd only convinced your father to go to the ED, he'd still be alive. Well, you couldn't convince him either when we were trying to get you into that, or you didn't want him to go. Things like that are helpful after the fact if any issues come up, which again are very rare. So we're not going to drive our practice based on avoiding, some kind of very rare liability, but by having good practice, it happens to protect us from that anyway. If you called in, which doc did you talk to? Did the doc talk to the patient? Again, doesn't need to happen all the time, but it's a useful tool. And then what is the patient's plan? What are they going to do? What did they tell you that they're going to do? The patient says they're going to go see their doctor. The patient says they're going to go directly to the emergency room from here and get evaluated. Show that we've basically done what we could to come up with a reasonable alternative to the plan, an alternative to our advice, which is let us take you to the emergency room to get looked at. So some useful terms here. I don't want you guys changing your practice so dramatically that we're transporting more patients than we otherwise would, because I don't think that's what's happening. I don't feel like there are patients that we should be transporting and not refusing who are refusing. I just think that we need to build a little bit more structure around that, both to protect you guys from having some issue come up, either liability issue or concerns or questions about care, but also to make sure that we're messaging correctly to the patient so they can make good decisions. So kind of things like, hey, we always recommend people come with us to the ED, but we have a process in place if you aren't interested in that. So it's a very non-judgmental way to say, hey, this is always our recommendation, but, it's not necessary that you come in. We're not going to kidnap you and drag you to the emergency room. Things like, I've heard medics really, really nice discussion of, we can't do a complete evaluation of you here with the limited equipment we have. We just don't have that technology. I've seen that, and that really kind of lays out the patient's need to understand that even though we have a lot of cool gear and we have them on a monitor and we maybe have done a 12-lead EKG or checked a blood sugar, that's a very limited evaluation, because the patient has no idea a lot of times that they see all this technology. They say, well, if the medic can't see anything here, there must not be anything wrong. Whereas we know as professionals that we do have some pretty significant limitations in what we can do. And then, things like, hey, we're worried you might have an illness or injury that we can't see right now and that might get worse. Again, laying out that we don't have a really complete understanding of what's going on, and that we're worried that the things that we miss may cause problems. There's some stuff that we want to avoid. Things that I've seen, our agency, some medics in our agency do. I've seen other medics do this, and these can be problematic because these go against the concept that our medical advice is that the patient should get transported to the emergency room unless they've changed their mind or they don't feel that they have an emergency going on, but that's still going to be a recommendation. So don't say things like, you don't need to go to the hospital today, or I don't see anything wrong with you. I wouldn't go to the hospital if I were you. This came up in a ride of giving a courtesy ride, which is basically the patient refused, but because the patient's car was damaged, we ended up transporting the patient to a different destination other than the ED as courtesy. That can look like an improvised alternative destination that's outside of protocol. Now, there's totally reasonable times to do that. It's freezing cold, the middle of the night, the patient has no transport, they don't want to go to the emergency room, but leaving them there is dangerous. Talk to the company officer and have some collaborative decision making about when this is appropriate, where, hey, actually, we're going to give you a ride to someplace safe because we don't want to leave you on the highway in the snow with a broken car and 10 degrees below at 1 o'clock in the morning. Again, that's totally reasonable, but don't use this as a way to say, well, if you don't want to go to the emergency room, maybe we'll give you a ride to your primary care doctor's office instead, or to an urgent care instead. That can open up a can of worms. It can look very strange if something ends up going wrong after the fact. Telling the patient, hey, you should just go see your doctor instead, before they've decided that they're going to refuse. That's perfectly reasonable to help them come up with a plan of, if you're not going to do this, would you at least agree to go see your doctor today? Things like that. But you can't lead with that, because again, that's going counter to the fact that we're that looks like we're doing paramedic initiated refusals, which we want to be cautious of. And so if our advice is to refuse transport, it's no longer in that against medical advice realm, which the whole concept of how we've built refusals in Denver Metro, it's built around that concept. So, again, I don't want this talk to change who you transport or who refuses. What I think is we can do a better job about how we talk to patients about refusals, how we think about refusals, and how we think about, consent and medical advice issues. The one place where I do think we have a change is there are many standing order refusals that we've seen in CQI where really that patient has a high-risk injury or medical complaint going on that really needs to go into the high-risk pathway with a biophone call to the ED doc to discuss that case and that refusal, and again, potentially enlist the help of that doc to try to convince the patient to do the right thing. The next video that we're going to do is actually going to cover some high-risk patients that seem low risk, because that's a different issue. So if you think the patient's high risk, but you use a standing order refusal, that's one issue. I also want to go over some patients who may seem low risk, but actually are higher risk and need to be bumped over into that protocol. So that'll be the next video that we go through here in a minute. All right, guys, so let's get to the third part of our CQI Lessons Learned series. So we're going to look at sick or not sick. So this is a common concept in pre-hospital medicine and emergency medicine, is the ability to look at a patient and determine if they're sick or they're not sick. You guys are great at that. You guys do that very well. There are a couple of patients, though, that we've seen in CQI where they didn't look sick, but really were high risk for other issues going on. So what I want to do is go through that a little bit. And we can break this down into a little bit of a matrix here. So basically, is the patient sick or is the patient fine? And does the patient look sick or do they look fine? And we can basically break that out into 4 different kinds of patients. So again, when you guys see a patient who looks sick and is sick, Chuck Norris says you guys are doing a great job with those, and so do we. So you're transporting them, you're providing good care to those patients, you're resuscitating them as best we can. We're seeing that repeatedly, and or if they are sick, look sick, and are refusing, we're considering that a high-risk refusal, and we're running through the high-risk refusal process of trying to advocate for the patient, trying to convince them what's going on, and just documenting our concerns and our risk. Now, you're also very good at the lots and lots of patients we encounter who look fine and are fine, who may wish to go to the emergency room, or we get into these little fender benders and the people are there and we go check on everybody. Nobody's got any injuries. Nobody wants to go to the emergency room. They may not even necessarily be a patient, depending on how we got called into that. And so we're really doing a good job with that. So there are some patients, too, that we see, and especially this time of year, who look sick and are fine. I would put the man cold in there, definitely. I certainly get those. I look terrible. I feel terrible. I'm fine. I'm going to be better in a couple of days. And so, not really so much of a problem for EMS and 911, but certainly something I think a lot of us experience in our personal lives. So where I want to go is to this bottom left quadrant, which is these patients who are sick but look fine, or maybe are at risk for being sick and look fine. And there's a couple of different things there, and I think that if we think about these specific patient types, that there's actually, this is where the high index of suspicion, assuming that there's an injury there until proven otherwise, and that approach is really going to pay off in making sure that we're not missing dangerous injuries in our patients, we're providing great care for them, and then we're not ending up with patients that we're doing CQI feedback on where it was kind of like, hey, this guy was a little bit more of a problem than it seems like you guys appreciated on scene. So we're going to go through some of those. So very first thing is vital signs are vital. And so patients who look fine but have abnormal vital signs, those should get our attention. There are lots of studies on the correlation between patient discharge from the emergency department with abnormal vital signs and death or other poor outcomes. Does that apply to the EMS realm? I don't think we have any good studies on that, but certainly if we have a patient who has vital signs that are outside of the normal limits, we have to think about why that might be and how that might contribute to the patient's risk versus someone who has normal vital signs. And really what the thing that I'm thinking about and that I worry about is, are the vital signs that I'm looking at that are vaguely abnormal suggestive of a compensated shock state, where the patient's compensating for being in shock? They're not looking like that because they're hanging in there, but they're at risk to crash later on. So that's the first thing we want to take a look at, is notice those vital signs. We had some low-risk refusals where the patient had some abnormal vital signs, like significant tachycardia that wasn't really addressed or discussed with the patient or included in the note. So little things like that we want to think about. So in that shock realm, we've seen a few cases over the last year of compensated cardiogenic shock, usually from a cardiac dysrhythmia, either a tachydysrhythmia or bradydysrhythmia. So what is compensated cardiogenic shock? This is where we're starting to have pump failure, but the vasculature part of the system, through clamping down, is sustaining perfusion, or at least sustaining blood pressure. And what you'll see frequently here is an abnormal heart rate, either this tachycardia or a bradycardia, with kind of a normal-ish blood pressure. And the reason why we worry about the compensated cardiogenic shock is what's going to convert that into decompensated shock. So things like pain and anxiety meds. This can be a little bit of a problem if we have a hypotensive bradycardic patient that we need to pace, we don't have good access, or we're hesitant about starting a pain or an anxiety med because of the low blood pressure. Sometimes the patient can run out of catecholamines. They can run out of epinephrine and norepinephrine that they're making, and that vasculature compensation falls down. The pump itself, if it's an ischemic issue or something like that, the heart itself, the myocardium, can get basically fatigued and further decompensate. Or the rhythm can deteriorate into something less stable. So it can go from bradycardia in the 50s to a bradycardia in the 30s, and now we've basically decreased cardiac output. So what are we going to do for these patients? Really, what we want to do is be ready to pace, defibrillate, or cardiovert. Or if that patient is in a bradycardia or a tachydysrhythmia with low blood pressure and any kind of signs of poor perfusion, our priority is very much to intervene on that patient and reverse it. And in fact, that priority is higher than the priority of sedation or pain medication, because really this is a life threat. And yes, cardioversion and defibrillation and pacing are painful. And if we can get a pain medication on there, or we can get some Versed on there, that is ideal. But we really don't want to let a patient die because we don't want the patient to be uncomfortable. And it says that right in the procedures. Consider pain medication. Consider sedating medication. So obviously get access. Don't forget the EJs. The cool thing about EJs is that they can be really big and distended when the patient is in cardiac, is having trouble with cardiac function. Because the heart's not pumping, you're going to get accumulation of blood on the venous side. So those EJs can be particularly useful in these patients. And then positioning, getting the head down so you can get a really good shot at that. Don't forget the IO option. Yes, IOs are painful. But there certainly are lots of examples, and even in some agencies that I've worked with on the federal side and the military side, that actually practice IOs on each other in the classroom. So this isn't something that's just an inordinately painful procedure. And so think about doing that if you don't have any access. If you do really need to get some meds on board, specifically pain meds. Also, don't forget about other routes. You've got, for pain meds, you got intranasal or intraosseous routes. You may not need to get that IV. If you can't get it and the patient really needs to be defibrillated, we may be able to do this through some different routes. One question that came up that was interesting is I had a medic who described that basically some teaching that a patient having ischemia from a STEMI or an NSTEMI, that pacing that patient with their bradycardia can potentially trigger a dysrhythmia. I don't worry about that. It's certainly anytime we pace a patient, we can trigger a dysrhythmia. That's always a possibility, but the pacing is not going to damage the heart as much as what's going on, which is bradycardic hypotensive cardiogenic shock. That low blood pressure is preventing perfusion of the coronary arteries that are completely or partially blocked in our STEMI or NSTEMI. And so by correcting that heart rate, increasing the cardiac output, increasing the pressure, even though there's a little bit more demand on the heart, it's now getting enough perfusion that it's going to compensate for the excuse me, compensate for the ischemia somewhat. So hypotension in the setting of cardiac ischemia is something that is definitely an emergency. That's an end organ dysfunction. That's shock, and we want to intervene on that aggressively. Pregnant trauma. This is something that's come up. And these are mild trauma. I'm not worried about these big high mechanism trauma patients. You guys are very good at recognizing and treating that. But we've seen some very low mechanism pregnancy trauma where this gets dropped into a low-risk refusal rather than a high-risk refusal. So if we're greater than 20 weeks, so we're into the realm of viability, and the patient has very low mechanism, this can be falling over on a laundry basket or a piece of furniture that has some direct trauma to the abdomen, seatbelt in a low mechanism MVC, airbags in a low mechanism MVC. What can happen is you can start getting bleeding from the edge of the placenta and the uterus that starts to basically dissect through. I'm going to get my pointer over here. So we have this blood that's accumulating, and what it's doing is it's going through and it's splitting the placenta off of the uterus. This can be completely painless. It can be so little of mother's blood that we're not noticing anything, but the baby can start losing significant amounts of blood because we've talked about blood in the blood in the umbilical cord, and part of the blood in the placenta is the baby's blood. And by the time this gets noticed, the child could be lost, and you could have an in utero death. So if this patient has trauma, even minor, with more than 20 weeks gestation, they need to go into the ED to get monitored. And usually they get admitted to the L&D floor. They monitor them for 24 hours. They'll do serial ultrasounds on them, make sure everything's looking good before they go home. Because if anything's wrong and you're at 26 weeks, 30 weeks, 35 weeks, and something's going wrong, and you can get that baby out into the NICU, and the baby does fine, versus this can be a complete loss of the baby very late in pregnancy, which is devastating. And we definitely want to avoid that. So if we look at the Denver Metro Protocol, it says the priority is the mother, transport all patients. Again, patient still has the ability to refuse, but this is a high-risk refusal. And then assure that the hospital is aware of the pregnancy and the gestational age greater than 20 weeks. And so we have the highlight here. Patients with any thoracic, abdominal, or pelvic complaint or injury may require prolonged fetal monitoring in the hospital, usually 24 hours, even if asymptomatic at the time of evaluation, and even for seemingly minor mechanisms. So this is a patient who looks fine, feels fine, but certainly can have something absolutely devastating going on that we don't know about. Another one that comes up, and this is kind of a universal thing, is the elderly low mechanism trauma, usually ground level falls or minor MVCs. So what the elderly have going on in trauma is that they can have injuries that aren't really apparent. They don't know that they're having them. Our physical exam may not reveal them. Many of them are on blood thinners. So in trauma, they're going to tend to bleed more and bleed faster and not be able to clot as much. Because of age-related atrophy in the brain, they have more room inside their head to bleed. So they can have a small bleed that's growing, and it can take a while before it's pushing on enough structures the patient has symptoms. These patients, they were built in a very different era. Many of these patients are extremely stoic. They're hesitant to go to the hospital. They're in significant denial about how injured they might be, or if they if they aren't in denial about the injury, they're in denial about how dangerous that injury might be. Their pain sensation can be hindered by medications, by neuropathy from chronic issues. Their balance is hindered. Where that's a problem is that because their balance is hindered, they may not be able to stop their fall like you and I would if we were to stumble. So they tend to fall harder than we do. They have diseases that affect cognition, and you may have someone that in a short interaction can really talk a good talk that they're fine, but they're confabulating. They're filling in details that they don't remember with plausible stories. They don't really understand what happens. They don't remember what happens. They may make up something that happened because they don't remember it, not intentionally, but just their brain is filling in the gaps with something plausible. And they may not really understand our concerns for what their injuries might be. The other thing, too, is that many of them are on blood pressure meds. This can hide a tachycardia because the patient may be beta blocked or in a calcium channel blocker, that we're not seeing a tachycardia that would be suggestive of dangerous injury or dangerous blood loss. Or the blood pressure medications make it hard for them to compensate, so that if they do end up having a traumatic injury or bleeding, the consequences are greater because the patient can't compensate for that bleeding, and so they may tend to go downhill relatively faster. And again, this is in the spinal immobilization section, because we repeatedly have seen, not just with North Metro, but also with other agencies in the emergency department, in the trauma reviews, in the hospitals, we see elderly patients with falls who don't get spinal motion restriction and end up having some pretty significant cervical spine injuries, even with no pain, no sensory changes, no tenderness to palpation. Because these patients, they just don't sense pain necessarily the same as we do as younger, healthier people. So we look at the notes. This is from spinal motion restriction. So if any reason you suspect a patient has a spinal injury, take measures to prevent inadvertent movement of the spine, spinal motion restriction. Patients over the age of 65 are at higher risk of spinal injuries, even from ground level falls. They have stiffer bones, they fall harder, they don't have the protective mechanisms, they may have kyphosis and issues like that, or even surgical fusions going on that a young healthy person might not have. And then use caution when assessing for spinal injury in elderly patients who are at much higher risk and may have minimal or even no symptoms of neck pain despite C-spine injury. So we want to remember that. We've had some patients definitely show up in the EDs from multiple agencies. This is a universal problem. When we revised our spinal motion restriction protocols, where we're just not putting everybody on a backboard and a collar who has got even the minimal spinal injury, I think there's a lot of people who didn't need that, who don't need that, and still don't need it, but we may have swung a little bit too far, and we have some patients who really could use this even though they're pretty minimal, and we're not doing it. So I think we need to come back just a little bit towards back where we were to get a good safe spot to be. The next patients who look fine but could be sick, these are our limited trauma patients. So let's go through trauma team activation criteria. I'm not going to go through the individual criteria that the hospitals use to do this, but usually the concepts are they will do a full trauma team activation. This is with definitive injury, penetrating injury to the head, neck, torso, or proximal limbs, where we have basically the torso, the kill box in play for injury. Abnormal vital signs. Patient requires, intubation or ventilation. So they have hard findings that suggest that there's an injury going on. These patients look sick and are sick. Now, for our limited trauma team activations, these are patients who don't meet the full trauma team activation criteria of physiologic or anatomical criteria, but their mechanism is concerning. And so these patients, they look good, but they have a concerning mechanism. And the reason why we're activating is that some of them have a dangerous injury, many of them don't. So this is sort of this system is actually designed to capture those patients who look fine, but their risk factors are so high that some of those patients do have a dangerous injury going on. And then also, if you look at the triage algorithm, other considerations come up. So these are patients who don't meet full trauma team activation criteria of anatomic or physiologic criteria. They don't meet mechanism criteria, but it focuses on risk factors and patient characteristics. Things like children, people with developmental delay, people who are homeless and don't have access to resources, people with other chronic medical problems that put them at risk for either having worse injury or potentially not being able to notice their injury because of, again, diabetes, neuropathy, neurologic injuries, and things like that. Again, they look objectively fine. We don't see any apparent injury, but they have a higher risk of having injury. So some of those patients may have occult injury. So limited trauma team activation, other considerations, those patients are, by definition, fit into that. So then we get to the other hold my beer and watch this patient. These are the intoxicated patients. I used to work with some agencies where I trained that didn't really have the quality of pre-hospital skills that we see in the Denver area. And one of the scariest things that I could hear on the biophone on report is, we're bringing you a patient, but he's just drunk, doc. At least half of those patients had severe traumatic injuries or medical emergencies going on, and it was being minimized because the alcoholism was what stood out. So what do patients who are intoxicated have that make them high risk but may look fine? So first off, they start off with poor judgment from being drunk. and they're making bad decisions that they may not want to tell us about, they may want to minimize. They have poor pain sensation when they're intoxicated. They may not notice their injuries. They have a really poor memory or history if they're significantly intoxicated, and they're not be able to tell us a very good story. I'm going to say it the nicest way I can. Some of our intoxicated patients have distracting interpersonal skills. They are aggressive, confrontational, annoying, trying to pick a fight, being unpleasant. These things make it really hard for us to evaluate the patients adequately because they just aren't cooperating with the exam, or they may be actively interfering with us to be able to evaluate them. Some of these patients may have some legal entanglements where they don't want to tell us what happened because whatever they did was somehow illegal or could get them in trouble. Or they may be in custody, which can distort what's going on. And after we get through all of that, we come back to poor judgment. They may not be able to make a good decision about what kind of care they want to have or what's wrong, or a good decision of how to tell us what's happening or cooperate with the exam. So all those things can make it so that some of our intoxicated patients have dangerous stuff hiding that we can miss. So yeah, many of those patients are just drunk, but be very cautious when you think that this patient is just drunk. I like to look at it as, is this patient drunk too? Is there something else going on, and the intoxication is the minor component of what's happening? Another case or two that came up is this issue of incomplete or non-displaced fractures. So these are patients who have some kind of mechanism of injury that they've got a broken bone, but the bone's lined up very well, or the fracture isn't complete. So they don't have a deformity, they maybe don't have a lot of tenderness. But what can happen with these patients is if they're weight bearing on the legs, or if they're using their injured upper extremity, that amount of strain can take a partial incomplete fracture, a non-displaced fracture, and turn it into a fully displaced fracture, even an open fracture. So walking on a fracture is a high stakes way to find the fracture. Non-displaced fractures are generally managed conservatively. We can put them in splints or a cast eventually. They're going to let that heal up on its own. But once that is displaced, they probably need reduction at least, may need surgery, longer-term casting, and things like that. So letting patients walk on an injured leg and completing or worsening a fracture is not a good thing. And we certainly have a lot of resources, a lot of folks respond to a 911 call for injuries in our district. It's not like we've got a rural agency where we've got an EMT and a medic showing up in a medic unit and there's nobody around to help. We've got a lot of help. Be cautious with these patients with lower extremity injuries. We're not walking them. I'm going to give the honorary mention of looks fine is sick. I don't want to do a whole PALS course, but I want to put in pediatrics here. And we hear this thing of kids look okay until they don't, and this concept that these kids are doing well and then they just fall off the cliff. If you train on this a little bit though, you find pretty quickly that's not true. The kids actually look bad, but we're bad at noticing that they're sick until they look really bad. So we have over-reliance on pulse ox, blood pressure, heart rate, whereas these kids can really be compensating well until they crash. And we under-rely on the physical exam component and serial reevaluation of the physical exam of skin signs, capillary refill, mental status, and work of breathing. Those things are going to change sooner than the hard vital signs will. And if we're just waiting for the patient to become hypoxic, hypotensive, or have an abnormal heart rate, by the time we see that, the patient may be too sick for us to really resuscitate well. So we want to get ahead of that, and we want to have a high index of suspicion. We haven't seen a whole lot of pediatric bad cases in CQI. So again, I think you guys are doing great, but anytime I'm talking about patients who look fine but are sick, I just want to mention the pediatrics because that's something we always want to keep in the back of our head so we can continue to do well. So that covers the patient who is sick but looks fine. Be careful out there with the man colds are definitely running rampant. We're going to have a bad respiratory season, so make sure you're taking all your vitamins and staying in shape and eating your vegetables and all that good stuff. And keep doing the good work that you guys are doing. So that is the end of our third section of the CQI Lessons Learned. I hope you guys found some stuff in here that's going to be helpful. It'll help you be able to continue to do a good job, maybe do a little better job, maybe make the job a little bit easier and a little less cognitive load when you guys are out there on the streets doing what you do. Thanks for all you do. If you have any questions or concerns, obviously email me or Colleen or Dr. Beckman. And let us know, and hope to see you out there on rides and CQI and when we're out and about. Take care.